Hi, and welcome to this paediatric podcast on urinary tract infections. So we're going to go through the definitions, causes of a UTI, clinical features, management, including which investigations to do, the acute treatment and prevention, and also the prognosis. So this is an important topic because UTIs are the commonest bacterial infection in childhood. They occur in about 3% of girls and 1% boys. Also, it may be the first sign of a congenital anomaly of the urinary tract, or vesico-ureteric reflux, VUR. So I'll just go through some definitions. A urinary tract infection is defined in terms of the presence of symptoms such as dysuria, frequency, loin pain, plus the detection of significant culture of organisms in the urine. Vesico-ureteric reflux, or VUR, is defined as the retrograde flow of urine from the bladder into the upper urinary tract. So just a brief overview of vesico-ureteric reflux. It's usually congenital and it occurs in about 1% of newborns. There's usually a strong family history, and just for extra information, there's 5 grades of severity. It's really important to diagnose because with reflux and a UTI can lead to renal scarring and eventually renal failure. So what are the causes of a UTI? Well, it's usually the result of the bowel flora entering the urinary tract via the urethra. The commonest cause is E. coli, and it's responsible for about 90% of UTIs, followed by Proteus and Pseudomonas infections. Proteus infections are more common in boys, and Pseudomonas infections indicate that there's a structural abnormality in the urinary tract affecting drainage. So now for the clinical features. Infants present less specifically than children. Just to go through a few of the symptoms, there's usually fever in both infants and children, lethargy, vomiting or diarrhea, febrile convulsions, and either poor feeding or anorexia. Infants also become irritable, can have prolonged neonatal jaundice and septicemia, while in children they have more specific symptoms such as abdo pain and very commonly frequency and dysuria. So on examination, you often don't find anything, but it's important to do observations, check if they're pyrexial, and remember you can always refer to the other podcast by Ed about fever in children. Check their blood pressure, heart rate, etc. Remembering that a UTI is a major cause of sepsis in young infants. Have a feel of the abdomen, as there may be suprapubic or loin tenderness, and also have a feel for any abdominal masses. It's important to examine the genitalia and the spine for congenital abnormalities, and also to do a neuro exam because there may be evidence of a neuropathic bladder. So what's the differential diagnosis? Well, for any febrile illness in babies, refer to Ed's previous podcast on a febrile child. But beyond infancy, dysuria without fever is often due to vulvitis in girls or ballantitis in boys rather than a UTI. So how is the diagnosis of a UTI made? Well, it's often the symptoms plus a significant culture of organisms in the urine, or any growth on culture of suprapubic aspirate. Has to grow over 10 to the power of 5 organisms per mil in pure growth from a urine sample. So how do you collect urine from an infant or a child? This can be pretty tricky. The ideal collection is from a clean catch sample. For example, you just give a pot to mum and tell her to catch the wee. This is obviously easier in boys than it is girls. Urine pads can also be used if a clean catch is being difficult. Sometimes adhesive plastic bags are used, but they're often a major cause of contamination. If it's really hard to get a sample, then you can do a suprapubic aspirate. But this is often only in severely ill children under the age of 1 year old. For older children, a midstream sample is used, or an MSU. Remember that contamination of a urine specimen may lead to a false positive diagnosis, which can cause a child to have unnecessary investigations, so you have to be careful. So this is a brief overview of the investigations you can do for a child with a UTI. Urine dips are useful in children only over the age of 3, and obviously urine culture is the mainstay of investigation. Blood tests are important if the child is systemically unwell, and the imaging involves firstly a renal ultrasound scan and sometimes an abdominal X-ray if renal stones are suspected, cystography, which can be direct or indirect, and radioisotope scanning, such as DMSA. The aim of the imaging is to identify structural abnormalities and urinary obstruction, vesicoureteric reflux, and cystography is useful for this, and to look for renal scarring, and DMSA scan is useful for that. So just quickly to mention the types of direct and indirect cystourethograms. The example of direct is an MCUG, which is a micturating cystourethrogram. Basically, insert a urinary catheter, administer radiocontrast into the bladder, and look for reflux when the child voids. It's for under 2 years old, and they're useful for grading the reflux that's seen. However, it does obviously require the child being catheterized, and there is a high radiation dose. So indirect cystourethograms, such as MAG3 or DTPA scans, are radionucleotide scans. They inject radionucleotide into the venous system and detect the progress through the renal tract using a gamma camera. They're for slightly older children, over 2 years old, and they're better in some ways because no catheterization is required and there's a lower radiation dose. However, they do cause false negatives, and you do need a child that can cooperate as they need to void on demand. So who gets which imaging? If the child is under 6 months, then they need an ultrasound scan within 6 weeks. But if they are older than 6 months and it's just their first UTI, you do not need any imaging unless there's features of atypical or recurrent UTI. Cystography is usually done after 3 months, and radioisotope scannings after 4 to 6 months. So I mentioned atypical and recurrent UTIs, and according to the NICE guidelines, this is how they're defined. An atypical UTI is a seriously ill child, or a child that has poor urine flow, an abdominal or bladder mass, raised creatinine, septicemia, or a poor response to antibiotics, and also any organism that's not E. coli. Recurrent UTIs means 2 or more episodes of acute pyelonephritis, or 1 episode with acute pyelonephritis with 1 UTI, or 3 or more episodes with cystitis. So moving on to the treatment of a UTI, basically it's antibiotics. If the child has cystitis and it's a mild disease, they just need 3 days of antibiotics, such as trimethoprim or coamoxiclav. If they have pyelonephritis, then it's also just oral antibiotics, such as trimethoprim, but it's for 7 to 10 days instead. If they're severely ill, such as with a high fever or vomiting, then they need IV antibiotics, such as gentamicin. So just a little bit about preventing UTIs. You need to avoid the predisposing factors, such as treat and prevent constipation, hygiene, avoiding nylon pants and bubble baths, and encourage plenty of fluids and regular toileting. Oral antibiotic prophylaxis, such as nitrofurantoin, is only if they've got VUR or recurrent UTIs. So just a quick summary of what we've been through. Discuss definitions of a UTI and a VUR, causes of a UTI, clinical features, management, including investigations, acute treatment and prevention, and the prognosis. Thanks for listening. See you again soon.